Okay, in our video series of pulmonology lectures, in this video we are going to talk about lung cancer, a very high yield topic. We are going to talk about different types of lung cancer, clinical features, diagnosis and treatment of lung cancer in detail. We have a case here. A 65-year-old man comes to your clinic complaining of cough for the last 4 months. Patient tells you that cough initially was less severe. Now the cough has been quite severe and it has been affecting his life. Patient tells you that the cough is productive and in the last 1 month he has noticed multiple episodes where there is blood in his sputum. There are episodes of hemoptysis. Patient tells you that doctor, in the last 3 months I have lost weight significantly. Patient shows you a picture of himself 3 months back where he was all healthy. Now he has lost weight significantly in the last 3 months. When you take the history, there is 35 pack year of smoking history. When you order the chest x-ray of this patient, you see a picture like this. Look at the opacity that is present in the chest x-ray. This is a picture of lung cancer. How do you confirm the diagnosis that this is lung cancer? How do you manage this patient? Today we are going to talk about it in detail. Remember, lung cancer is the second most common cause of cancer overall. On the top is breast cancer in females and prostate cancer in males. Second to that, in both males and females, is lung cancer. But remember, the mortalities caused by lung cancer are the highest. Leading cause of death due to cancer is lung cancer. It's not the breast cancer or prostate cancer. By incidence, it's the second most common. By death, it is the leading cause of death by cancer. It affects male more than females, except adenocarcinoma, which is a type of cancer that is more common in females. Remember, the most important cause of lung cancer is tobacco smoking. Remember, tobacco contains lots and lots of carcinogens that can result in lung cancer. Nicotine in tobacco is addictive. Nicotine does not cause cancer. It's the carcinogens that are present in the tobacco that cause lung cancer. Tobacco smoking is recorded in pack years. 1 pack year means that the patient has been consuming 1 pack of cigarettes per day for the last 1 year. That is called as 1 pack year, and 1 pack of cigarettes contain 20 cigarettes in it. So if the patient has been consuming 1 pack per day for the last 1 year, that is 1 pack year. If the patient has been consuming 2 packs per day for the last 1 year, that is 2 pack year now. Radon is the second leading cause of lung cancer. Radon is a radioactive material that is present in the soil, and those who are living in the basements are more prone to radon exposure because the ventilation in the basement is low. Asbestos exposure can result in lung cancer. Remember, I have a full detailed video on pneumoconiosis where I have talked about asbestos and how it causes lung cancer, the bronchial carcinoma. Asbestos exposure can also result in lung cancer. Asbestos is present in the insulations that is placed in the walls and in the roofs. Those construction workers who have exposure to asbestos continuously, those who are working on the roofs, these patients are at risk of developing lung cancer if they have an exposure of 20-30 years. And remember, if the patient is exposed to asbestos and that patient is also a smoker, there is a synergistic effect and that patient will develop lung cancer very rapidly. I have talked about asbestos exposure in detail in my video on pneumoconiosis. And there can be a family history where someone else in the family is also affected by lung cancer. But remember, tobacco smoking is the most common cause, radon as the second leading cause of lung cancer. Lung cancers are broadly divided into non-small cell lung cancers and neuroendocrine tumors. Non-small cell lung cancers include adenocarcinoma, squamous cell carcinoma, large cell carcinoma. Neuroendocrine tumors include small cell lung cancer, bronchial carcinoid tumor, large cell neuroendocrine tumor. The most important one on this side is small cell lung cancer. Many of the books won't even mention these two. So we are mainly going to discuss small cell lung cancer in this video. And we are also going to discuss all these cancer. Some books also classify it into either non-small cell lung cancer or small cell lung cancer. But I have mentioned here the more types, the bigger category, the neuroendocrine tumors over here. Now, we'll be proceeding ahead and talking about small cell lung cancer, which is a very important lung cancer. And this is the cancer that is tested many times in exams. Now coming to small cell lung cancer. Remember, small cell lung cancer is located centrally. Centrally means that it is mainly located in the center of the lungs, near the bronchi, near the major vessels. And it is associated with smoking. You can simply remember it with the S's. Small cell contains an S. It is associated with the smokers, and it is also central. So we have the S, S and C, which sounds like an S. So if you have small cell cancer, it is common in smokers and it is mainly central. So you can remember it like that. Now these small cell lung cancer and other lung cancers can produce these paraneoplastic syndromes. Paraneoplastic syndromes are some systemic effects that are produced by these cancers. Lung cancer can produce systemic effects. It can cause Cushing syndrome when it produces ACTH. It causes production of ACTH, and that ACTH stimulates the adrenal glands to produce lots and lots of cortisol. So these patients can present to you with features of Cushing syndrome. It can also produce SIADH, resulting in syndrome of inappropriate ADH secretion. It can also produce antibodies that block the presynaptic receptors, and when they block the presynaptic calcium receptors, they cause muscle weakness that is seen in the Lambert-Eaton syndrome. Very important, very high yield. These paraneoplastic syndromes are tested many times in the exams. These patients can also present to you with paraneoplastic cerebellar degeneration, where these antibodies are destroying the cerebellum and they are causing ataxia, abnormal gait in these patients, and all the cerebellar signs. So lung cancer can produce some systemic effects, and these systemic effects are maybe caused by production of certain hormones, or they can be due to certain antibodies, and those antibodies are producing these effects. Squamous cell lung cancer is a very aggressive tumor and it causes early metastasis. L-MYC oncogene mutation has been associated with small cell lung cancer. This is an MCQ point for USMLE step 1, where they will ask you that which type of oncogene is associated with small cell lung cancer. On histology, you will find a picture of neuroendocrine cells that are called as Kulczycki cells. I will show you the picture of Kulczycki cells. That's the classical picture of neuroendocrine tumors. And on step 1, they often ask you that a patient is having, they will show you a picture of Kulczycki cells and they will tell you there is a neuroendocrine tumor. And remember, the most important neuroendocrine tumor in the lung cancer is small cell lung cancer. And these neuroendocrine tumors express certain tumor markers, and those tumor markers are chromogranin A, synaptophysin, neuron specific enolase. So these tumor markers will also be positive, and there will be a picture of Kulczycki cells. They will show you a picture like this. They will tell you that the patient is having cough, weight loss, hemoptysis for the last 4 months. Patient has a significant smoking history. Now, which type of cancer is that patient having? This is a classical Kulczycki cell picture, a neuroendocrine tumor. They might also tell you that patient is chromogranin or synaptophysin positive. Remember, this is a neuroendocrine tumor and they are talking about small cell lung cancer. And make sure to remember all the paraneoplastic syndromes of small cell lung cancer. Small cell starts with an S, therefore it is found in smokers and it is central. Now we will be going to the squamous cell carcinoma. I have sequenced these cancers in the video according to their importance in the exams, according to their importance in real life. Most of the times you will be able to find squamous cell carcinoma, small cell carcinoma, adenocarcinoma. So I have sequenced them in a video so that you know them according to their importance. Squamous cell carcinoma is a very important lung cancer. Squamous cell carcinoma, as its name starts with an S, it is associated with smoking, and it starts with an S, therefore it is central. So that's an easy way to remember squamous cell carcinoma as well as small cell lung cancer. The paraneoplastic syndrome associated with squamous cell lung cancer is parathyroid hormone related peptide secretion. This lung cancer, squamous cell produces parathyroid hormone related peptide that causes hypercalcemia. How does parathyroid hormone cause hypercalcemia? I have explained that in detail in my video on hyperparathyroidism. So there is an ectopic production of parathyroid hormone related peptide that causes excessive absorption of calcium from the kidneys. It causes activation of vitamin D in the intestines, resulting in absorption of the calcium. It leaches out calcium from the bones. Therefore, it is resulting in hypercalcemia. Very high yield point. In the lung cancers in exams, they most of the time will tell you the paraneoplastic syndrome, and they would want you to know which type of cancer they are talking about. On histology, you will be able to appreciate keratin pearls and intracellular bridges. Remember, all the things that have squamous cells in them will have keratin pearls and intracellular bridges positive. This is a picture showing keratin pearls. Must memorize this picture. These are classical keratin pearls. If you memorize this picture and if you remember these keratin pearls, it is very easy for you to diagnose that this is squamous cell lung cancer. Keratin pearls and intracellular bridges, these are classical hallmarks of squamous cell tissue. Now we will be going towards adenocarcinoma. Adenocarcinoma of the lung is most common cancer in women. It is also most common cancer in non-smoker. Now you see, adeno starts with an A, and therefore it is not central. It is not associated in the smoker. So it is an easy way for you to remember these lung cancer. If it starts with an S, most likely it is associated with smoking, and most likely it's central. If it starts with an A, most likely it's peripheral, and it is in the non-smokers. An important point is that it is the most common cancer in women. Most common cancer, more common than males. Paraneoplastic syndrome associated with lung cancer is hypertrophic osteoarthropathy, which is also called as Pierre-Marie-Bamberger disease, a very huge difficult name, but you must simply remember that it causes hypertrophic osteoarthropathy. Now, what is hypertrophic osteoarthropathy? Basically, it causes inflammation of the periosteum layer on the bones. When it causes inflammation over the layers of the bone, it will result in arthritis. It will result in joint pains. It can also result in periosteal inflammation and result in clubbing in the nails. So that is a periosteal reaction resulting in hypertrophic osteoarthropathy, pain in the joints. Clubbing is seen in this. Mutations of EGFR gene and ALK gene are associated with lung adenocarcinoma. Do you remember which mutation was associated with small cell lung cancer? It was the L-MYC gene mutation that was associated with small cell lung cancer, and adenocarcinoma is associated with EGFR and ALK gene. These are common questions on USMLE Step 1 exam. Prognosis is better than other types. Coming to the histology picture of lung adenocarcinoma, remember, whenever they take the word adenocarcinoma, a gland should come into your mind. Whichever adenocarcinoma they are talking about, a gland should come into your mind, because it is a glandular tumor. And glands, what do the glands produce? They produce mucin. Positive mucin staining will be there. There will be mucin producing cells because it is a glandular tissue. Now coming to large cell carcinoma. Large cell carcinoma is peripheral because it starts with an L. L is peripheral. But it is an exception to our general rule. That general rule does not apply over here because this large cell carcinoma is common in smokers. But otherwise, you can apply that simple rule and remember this simple exception. You will be good to go for the exam. Paraneoplastic syndrome include gynecomastia because it produces human chorionic gonadotrophin, and that human chorionic gonadotrophin can cause gynecomastia. This is very important. Gynecomastia is associated with large cell carcinoma. Now I'll be briefly talking about bronchial carcinoid, a neuroendocrine tumor which is not very high yield, but you can simply remember it that it is a central, it can be a peripheral lung cancer. The important point is that carcinoid tumors produce serotonin, and whenever they produce serotonin, they result in flushing, they result in diarrhea, and it is a neuroendocrine tumor. So the main important point is whenever you hear the word carcinoid, serotonin should come into your mind. And what does serotonin syndrome cause? It causes flushing and it causes diarrhea. Now coming to the clinical presentation of lung cancer, it will be very simple and easy for you to remember the presentation of lung cancer. The classical presentation, the patient would be having cough, patient would be having history of smoking, patient will be having hemoptysis, episodes of blood in the sputum, and there will be significant weight loss because there is a tumor growing in the body and that tumor is taking all the nutrition from the body. In the later stages, it can cause dyspnea, it can cause wheezing if it is blocking a bronchus, it can result in wheezing, and it can also result in chest pain because there is a mass growing inside the chest. Now coming to the extrapulmonary features of lung cancer. Whenever lung cancer grows, it can compress the things that are lying around the lungs. Now, if there is a mass, if there is a lung cancer that is present in the upper lobes of the lungs, it can compress superior vena cava. And when it compresses superior vena cava, what will happen is that the patient will start developing edema of the face. The venous drainage of the face will be poor. Therefore, this patient will be having facial edema, there will be flushing of the face, the veins will be dilated over the face. That is called as superior vena cava syndrome. Whenever the mass in the upper lobe obstructs the major vessel, superior vena cava, resulting in poor drainage, there will be edema of the face, there will be dilated veins present on the face, and there will be flushing because the blood is not being drained properly. That is called as superior vena cava syndrome. When it involves recurrent laryngeal nerves, when the mass involves the recurrent laryngeal nerve, patient will be having hoarseness. And remember, if the patient has hoarseness and the patient has lung cancer, this shows that this is an unresectable lung cancer. Usually hoarseness is a sign that this is an unresectable cancer. Diaphragm elevation can occur whenever it involves the phrenic nerve, and it causes paralysis of the phrenic nerve and paralysis of the diaphragm. Lung cancers can grow backward and cause esophageal compression, resulting in dysphagia. It is very important and a high yield clinical point that if a patient is having recurrent respiratory infections, pneumonias in the same pulmonary lobe, you treated that patient with antibiotics, that patient went back, and again that patient developed pneumonia in the same pulmonary region, and the patient's age is greater than or equal to 40 years, it should always raise suspicion for lung cancer, because lung cancer can block the airways, and when the airways are blocked, it can result in the bacteria to grow there, and when the bacteria grow there, it will result in recurrent episodes of pneumonia in the same pulmonary region. So if a patient age equal or greater than 40 develops recurrent pneumonias in the same pulmonary lobe, suspect lung cancer in that patient and screen that patient for lung cancer. For the metastasis, you can remember a simple mnemonic: lungs love to blab. B for brain, L for liver, A for adrenal glands, and B for bones. So the mets of lung cancer will go to all these places. A simple mnemonic to remember it. Now coming to the diagnosis of lung cancer. Whenever a patient comes to you with the clinical complaints of cough, hemoptysis, weight loss, and you suspect that the patient is having lung cancer, the first thing that you do is that you do chest x-ray to find out the mass, to find out any sign that that patient might be having a lung cancer. In some cases, you might find effusion. If you see an effusion and that patient has signs and features of lung cancer, the next thing you do is that you tap the effusion and you send that effusion sample for cytological evaluation, because many lung cancers can present with effusions, especially adenocarcinomas, because adenocarcinomas are mucin producing tumors, and these mucin producing tumors have the tendency to produce effusions. Tumors or lung cancers that are caused by asbestos can present with effusions. So if you suspect that patient has malignancy and there is effusion present, you must tap the effusion, send it for cytological evaluation. What they do is that they look it under the microscope and look for the abnormal cells, malignant cells in there. If you do the chest x-ray, and on the chest x-ray you see a mass, the mass like the patient in our case had. If you see a mass, the next thing you have to do is that you have to go for the CT scan. You have to localize the mass, that where is this mass present. You perform a simple CT scan. You do not perform HRCT. HRCT is done in patients with interstitial lung disease, where you want a detailed picture of the lung parenchyma. We do simple CT scan in lung cancer patients because we want to find out the mass, we want to find out the enlarged lymph nodes, and they will be more prominent on a simple CT scan. So you do a simple CT scan, and on the CT scan, if you find the mass is present in the bronchus, what you do is that you do bronchoscopy and take a biopsy from this mass. If you find that this mass is present in the peripheral region, what you can do is, or if it is present in the pleural region, what you can do is that you can take CT guided pleural biopsy. You pass a needle and you take the biopsy from the pleural region or whatever peripheral mass is there. Now, if there is an effusion present, what you do is that you do thoracocentesis, you tap the effusion and you send it for cytological evaluation. Now, in some cases, what would happen is that the mass will be present in the center of the lungs and it will not be reachable by the bronchoscope because it is lying outside the bronchi and you cannot reach it through the bronchoscope. And you cannot also pass the needle and take away the sample directly because there is risk of lung rupture. You can only pass the needle and take sample if it is lying on the outer side in the peripheral region, in the pleural region. In such cases, you can pass the needle and take the sample. In such cases where it is located centrally and you cannot take the biopsy through bronchoscope or passing the needle, what you do is that you go for a video assisted thoracoscopic surgery. This is also a therapeutic procedure as well as a diagnostic procedure where they get inside the center of the lung and they remove the whole of the lesion through a thoracoscope. So this is how you do workup of lung cancer. Whenever you suspect lung cancer, you do chest x-ray. If you find effusion, you tap the effusion, do cytological evaluation. If you find a mass, you must do CT scan, and after the CT scan you have to do the biopsy, and on biopsy you can find out which type of lung cancer is there. If the lung cancer has already metastasized to different body organs like brain, bones, adrenal glands, liver, in such cases what you can do is that you can perform a PET CT scan that gives you a whole picture of the body. They give the dye to the patient and the dye spreads out and is taken up by the lung cancer and the mets, and then you take a picture of the body and it tells you all where these mets are present in the body. So PET CT is done if there are already mets present. Now this is a picture showing the lung mass. The lung mass needs to be investigated and this is most likely a lung cancer. See, this is a CT scan showing the mass. This is another picture showing mass present in the peripheral region. It is important to note that 90% of the tumors with malignant effusions are non-resectable. If you find an effusion and that effusion turns out to be malignant, it is a clear-cut indication that most likely this cancer is adenocarcinoma and it is non-resectable. If there is malignant effusion, it is most likely non-resectable in 90% of the cases and it is caused by adenocarcinoma. A normal chest X-ray does not rule out lung cancer. 10 to 20% of the patients will not have any findings visible on X-ray. So must do CT scan even if you suspect lung cancer in patient. Now coming to the treatment of lung cancer. Treatment of lung cancer is limited. The first thing you need to see is that whether it is a resectable lung cancer or is it an unresectable lung cancer. Unresectable lung cancers are the one where there are extra thoracic mets, mets to the bones, mets to the brain, mets to the liver. These are unresectable tumor. If there is superior vena cava syndrome, because that has already this mass is compressing the veins, this cancer has most likely spread to other organs as well. If there is hoarseness present, if there is CNS involvement, or if there is huge pleural effusion, most likely these patients are having unresectable lung cancer which won't respond to the treatments. So palliative care is given in such cases. If the tumor is resectable and on biopsy you see that it is a small cell carcinoma, small cell carcinoma can be treated with chemotherapy and surgery is not required. It can be treated with etoposide combination with platinum. These are chemotherapy drugs. Chemotherapy drugs are given in small cell carcinoma. If it is a non-small cell cancer, in such cases you give CAP therapy, cyclophosphamide, adriamycin and platinum, and radiation is also given, and surgery is also performed in patients with non-small cell lung cancer. So the main important thing is that whether it is a resectable tumor or an unresectable tumor. Chemotherapy mainly for small cell and chemotherapy with radiation therapy with surgery for non-small cell lung cancers. Surgical options include sublobar resection, where you remove the lobe, part of the lobe that is having the cancer, or lobectomy, where you completely remove one lobe of the lung, or pneumonectomy in some cases where you completely remove one lung from the patient. Prognosis is best with squamous cell carcinoma. Overall, you must remember that lung cancer is a lethal cancer. Overall, the prognosis is worst. Lung cancer is a deadly cancer. Whatever type it is, lung cancer has a poor prognosis. But among these lung cancer types, the best prognosis is with squamous cell carcinoma, and even with squamous cell carcinoma, recurrence can occur within 6 months. So if this is the condition of the best prognosis lung cancer type, then the worst can be even worse than this. Poor prognosis is associated with small cell carcinoma. Overall, there is poor prognosis of lung cancer. It is a leading cause of death for a reason. Now, coming to the screening of lung cancer, who do you have to screen for lung cancer? Remember, screening of lung cancer is done with annual low-dose CT scan. It is a beautiful MCQ point, many times asked in the questions, that what thing is used for the screening of lung cancer. It's not chest X-ray, it's annual low-dose CT scan that is done for the screening of lung cancer. And in whom you have to go for screening? In patients aged 55 to 80 who are either current smokers or have quit smoking less than 15 years ago. It is important that you remember less than 15 years. And they also have a history of greater than 30 pack years smoking history. Now you would be thinking that why don't we screen patients age greater than 80? If the patient's age is greater than 80, even if they are diagnosed with lung cancer, you cannot provide many of the treatment modalities, because how much a person can live after the age of 80? These treatments are more lethal than no management of a lung cancer. So most likely after age of 80, these patients do not require any screening. Or if the patient has quit smoking greater than 15 years ago, if the patient has quit smoking greater than 15 years and in the 15 years he has not developed any complication, you do not need to screen that patient. So this is how lung cancer screening is done. If you liked my video, please make sure to click the subscribe button and make sure to check out my other lectures on pulmonology lecture series, neurology lectures, emergency medicine lectures. You can also follow me on Instagram and you can support this channel on Buy Me a Coffee. Lung cancer is leading cause of death and second most common cancer by incidence. Tobacco smoking, most important cause. Radon, second leading cause. We talked about the classification of tumors. We talked about small cell lung cancer. Must remember the paraneoplastic syndrome. L-Mike mutation is seen. Central smoker, small cell. Then we talked about the neuroendocrine Kulczewski cells. This is a picture of small cell lung cancer. Squamous cell lung cancer. Squamous cell, central, smoking, all the S's. Paraneoplastic syndrome, very important. Keratin pearls are seen. Adenocarcinoma of lung, the most important point is hypertrophic osteoarthropathy is seen. EGFR, ALK gene, most common in women, very important. Histology will show positive mucin staining because they produce effusions. Large cell lung cancer occurs in the peripheral lung and it is associated with smoking. Gynecomastia, very important. Bronchial carcinoid tumor produce serotonin resulting in flushing and diarrhea. Clinical features include cough, hemoptysis, weight loss, superior vena cava syndrome and other extrapulmonary symptoms, very important. If a patient has recurrent pneumonias in the same lobe greater than age 40, must screen for lung cancer. Where the MET scan takes place. We talked about diagnosis, chest X-ray being the initial test, must do CT scan, must do biopsy to diagnose the type of lung cancer. 90% of the malignant effusions are unresectable and they are adenocarcinomas. A normal chest X-ray does not rule out lung cancer. For if it is an unresectable tumor, these features are there. If it is a resectable tumor, chemotherapy, radiation therapy, surgery can be done. The surgical options that are there. Prognosis is poor. Among these lung cancer types, squamous cell has better prognosis than others. Screening is done with annual low-dose CT scan. If you like my video, please make sure to click on the subscribe button and make sure to watch out my other lectures on neurology, pulmonology, emergency medicine. Support us on Buy Me a Coffee and follow us on Instagram. Thank you very much.